So our next speaker is Dr. Mohamed Salama from Mayo Clinic. He's a professor at Mayo Clinic in pathology and lab medicine. And he's also the medical director of the Mayo Clinic Reference Lab, which is one of the largest reference lab for pathologists who need a consult or need to send esoteric testing. So it's one of the larger reference labs in pathology. Dr. Salama also serves as the senior associate consultant in the division of hematopathology, and he is previously he was at Utah, at the University of Utah. He was chief of hematopathology and vice president of the ARAP lab, which is another big reference lab. So Dr. Salama has received his medical degree from Cairo University. He's also received a diploma of hospital administration, healthcare management, and has trained at Henry Ford. He's done surgical pathology at Stanford, Hemepath at University of New Mexico. And he's published a lot in this area, especially on all aspects of Hemepath, including morphology, flow cytometry, lymph nodes, bone marrows. His research focus is on genetic and molecular aberrations of in Hemepath, and he's done a lot of work in digital pathology and digital imaging. Like he's the person we think about when we think about Hemepath and digital pathology. So I'm really, and he's extensively published in this area, and he's published books and book chapters, including being the co-editor for one of the premier hematology books called Hoffman's Hematology. So I'm really, really honored to have him come and speak to us today about his experience in hematopathology, being at a large reference lab in pathology, and what is his vision of the future of computational pathology and AI as it pertains to pathology, but more specifically Hemepath. So Mohamed, welcome, and please, we're excited to have you here and listen to your insights. And
thank you, Anil, for this presentation. I mean, it really makes me humbled to hear you say that. But I'm grateful for the invitation. And so should I?
If you can share your presentation, that would be great.
Yeah, please go ahead, Mohamed.
Do you see my screen?
Yes.
Perfect. So I'm going to start with my disclosures. As a background, basically digital imaging makes pathology quantitative science, and we'll focus, as Anil indicated, on primarily the Hemepath here. But what's the promise of digital pathology and AI? I personally believe every image-based pathologist and hematopathologist will use computer-assisted analytical tools in the future. Digital pathology enables AI, as we know. We know AI have been around since 1956, but we are talking about it now in a different way because the availability of data, digital data. And the one thing I want to stress out, and I will refer to it quite a bit throughout the talk here, is that AI extends really beyond imaging. I anticipate in the future that there will be more reliance on pathology, as well as higher integration and connectivity with management system, information system, whether it's a lab or electronic medical records. Why do we want to switch digital? We want to switch digital because we know from our predecessors in radiology that we have improved quality, improved access, consistency of workflow can be greatly improved. So what are the problems in hematology? In the hematology lab, it's a very labor-intensive process. Counting slides, whether it's a peripheral smear or a bone marrow, creates a perfect environment for imaging and AI to help standardize the process, make it easy to train. This area particularly is slightly harder to train, and you don't have historical images. I can tell you so many times in my sign out every day, and I still practice and I still see cases. when a resident bring a case to me and say, I think there is one blast here. And my blood pressure goes up because I just have to keep going back and forth on slides and find this blast that potentially never existed. And he just cannot point it up. So these becomes very helpful, particularly for traceability. So a couple of important concepts, how viewing image from a glass slide is different than the microscope in HemPath. This is a peripheral blood smear, and if we take an area and we dive in it, I can tell that this is a neutrophil by the way the nuclei are segmented. And if you go into the NSAIDs, you can see that one of the granules in the cytoplasm in NSAID B is made of about 16 pixels. So this have ramification. The quality of the imaging itself have ramification, because for me to view it, I may be able to label this patient with hypogranularity, which can result into a bone marrow biopsy and a lot of unnecessary testing that if I don't see these granules wells, because depending on the method that the image is generated. We know how the whole slide imaging work, but I just want to highlight the fact that oil scanning or high magnification scanning remains to be an area of unmet need. We did the study a few years back where we found that you can scan 9 by 9 millimeter area on slide, you need about 16.6 minutes in average. It still remains one of the main hindrance for the progress in digital pathology and AI in HemPath. There are a lot of vendors coming out now with more capability. However, that still remain limited. We think there's a lot can be done here. So it's not only scanning the slides at oil magnification, but there are some pre and post modification that can happen that actually can help significantly. Remember what I showed you before was only for the fact that how I can see the slides on the screen. It's a different story what the computer and what the AI does with the image, because this is a very fertile field for research and exploration here, because if the computer can do at 20x scanning, doesn't matter, because we can do a post-processing. Now we can speed the scanning, and if it's accurate, then we can do post-processing modification techniques where we can see the cell as if it's 100x or higher magnification oil scanning. I would like to think about the future of digital pathology and AI as a pathologist-centric system. So basically either at the time of scanning, at the time of diagnosis, at the time of reporting, and we'll go through these together. And we think, or I think there is a lot to be done both pre and post activity for the pathologist. Quality assurance can be happening in the background all the time. And really, I thought the best way to go through this is maybe go through some applications. Some of it is NF and actual effect, and some of it very close to come. And I would like to think about this in the lab in 3 different components. So pre-analytical, analytical component, and post-analytical. And most what people think is usually the analytical component. So we will talk about analytical examples, some pre-analytical examples like the case assignment, screening slides, pre-order of stains, and then the analytical, some automated cell classification or assisting in the differential diagnosis, and show some of the work that's done in the field. And finally, post-analytical related to natural language processing for report generation, among other directed repetitive functions. And then I will finally touch on some of the promising work that's coming in the field of flow cytometry as an ancillary testing, which obviously spans all the stages. So I will start with the pre-analytical. And for us to see how this is going to look in the future, we need to step really in the future, then backcast to chart our course moving forward. And believe it or not, this is existing today. We have seen this before. So prioritization of cases. But how prioritization of cases is going to affect me, help me as a hematopathologist? We'll assume that this is a case of acute promyelocytic leukemia. Obviously, we don't know at the beginning if this is acute promyelocytic leukemia, so the AI is going to screen the slide for me, even before I come, 1 a.m., assuming that this happened 1 a.m. or even 6 a.m. or 10 a.m. The slide comes, the AI algorithm looks at it, knows that this is promyelocytes, may even order the MPO stain or flow cytometry or FISH and start this. By the time I drive there, within an hour or 30 minutes, I can make the diagnosis. This is an APL diagnosis can be made in an hour, exactly an hour when the slide comes, which essentially nowadays it's unheard of. But we need to be we need to think of this as this is actually one of the few emergencies in HemPath, because if the diagnosis takes more than 24 hours or 48 hours, really the likelihood the patient will expire goes more than 50%. So it's important, and the FISH takes 24 hours. Flow cytometry needs to be done in the same day. So these are important to integrate in our day-to-day operation. Another example of the pre-analytical support is IHC selection. This is a case of 56-year-old female, pelvic mass. We did the mass, the diagnosis of Burkitt lymphoma. I get the case early in the day. It's going to take me a while because I can look at it, whether I can tell it's a Burkitt or diffuse large B-cell lymphoma. I need to do the first set of immunostains, takes 24 hours. I know it's a B-cell. I do the second set of immunostains, takes another 24 hours. But if the AI can tell from H&E with a very high level of confidence and do these stains at one set up front, it would be important. Also, it's important for me to pick up the phone and call the clinician very early in the day before it gets busy, before the patient even leave the hospital and have to come after 3 or 4 days. Now, we have shown that this particular question for separating Burkitt lymphoma and diffuse large B-cell lymphoma can perform very well with a very high level of accuracy. And essentially what I'm referring to here, this is a list of immunostains. You cannot do all of these immunostains, but if I know this is a Burkitt lymphoma, even without me looking at a slide before I come, at 7 a.m., it comes out of the processor and the scan and the stainer. They put the stain, they put the right stains, whether the first group or the second group. I can potentially come by 10, 11, 12 o'clock and sign out the case because the right stain have been ready for me. Again, significant improvement, not only in the turnaround time, patient satisfaction, the physician satisfaction, and more importantly, the cost, because now I'm doing staining. I mean, we are talking about each panel of those could be several $100s that could be saved. I'm going to move into the analytical part, and mostly we think about the analytical part of making when we think of AI and digital pathology. So manual differential, why do we want to automate this? Because consistently we are having shortage of technologists, less graduates, more retirement. We need there is a greater need for standardization and consistency of manual differential. And obviously there is an increased demand of connectivity. So this is really what happened in real life. I would be looking at a microscope under the slide. This is what you would see under the slide. And I have this friend here, the clicker, which I keep clicking, whether it's 100 cell or 500 cells in the bone marrow. And I put it on either on a piece of paper or on a digital form on the computer. And then this is transformed. Can you imagine how my life is going to look like if somebody's organizing these to me and actually giving me the count? All what I have to do is just look at it and say, agree, don't agree. So that's saving several minutes per case. That's a significant saving during the day. The automated classification of hematopoietic cells is not new. I've been around since the 60s with the CDX scanning microscope from Sweden. This quickly was replaced by the automated flow cytometry-based CBC, which actually it does hundreds of thousands of cases, but there are still some percentage that they get flagged for abnormalities, or the clinician wants these abnormalities, and this is where the counter is used. There are several modern digital morphology and remote viewing systems, and we will just briefly touch on those. So the medical system, the television system, and these can come in both a hardware and a software. The main difference between them, as you can see, the television can come as a separate system or a modular system that get attached to the Sysmex for a high volume labs. And really the main difference between these systems is the number of cells, number of classes, and what's pre-automated, upfront classified or pre-classified to be confirmed by the operator. They provide a significant value. As you can see, finding abnormal cells fast, you can see high resolutions of cells. You can use those for proficiency testing. You can do things like the standardized platelet estimate in the left upper corner, where you actually can look at the images and confirm the pseudo count that could happen by the machine. You could have a standardized red blood cell viewing tools. You can sort them by size, by shape. You can point out spherocytes. You can actually do a combination of all of those. So this is significant. But what is an ideal digital pathology platform? An ideal digital pathology platform would be an agnostic image acquisition. Actually, you should be able to accept images from any system. And we know this is possible now with AI. And we'll talk about the analysis in a second and how things have progressed over the years and where they are going. Deep machine learning is essential. It provides accuracy, it can handle stain variability, it gets better over time. And ideally, the same system can do other things. So not only blood, but it should be able to do bone marrow aspirate, should be able to do some other cytology specimen, pap smear, some other even clinical lab testing, fecal specimens and other things as well, and urine. And obviously, it enables remote morphology. All of these systems that I have shown you exist today, they are actually dependent on a simple knowledge-based artificial network algorithm that employ the typical hierarchical structure classification rules that we use that mirrors our manual teaching process to our residents and fellow. And it follows very simple process of identification of the white blood cells, the segmentation of white blood cells, and then classification of white blood cells and the red cells as well. There have been a lot of studies, including some earlier one from our group, but they have shown a very similar performance. What's new recently is that the deep learning and AI started to be employed. And as you can see here now, the performance starts to go up significantly. The one thing I want to point out, most of studies have been done, it use only 2 or 3 or 4 classes. And as you look at 4 or 5 classes, then the performance still becomes high. What you are seeing here is an abstract that I have seen in 2019 from the Spanish group, which basically as you try to challenge the AI system with different diagnoses like CLL or plasma cell dyscrasia or splenic marginal zone lymphoma or T cell abnormalities, then you can see the performance starts to go significantly lower. Why this is important? The International Consortium for Standardization of Laboratory Hematology have actually proposed in 2015 that grading of abnormal cells and nomenclature should be standardized across the globe. And I want you to take a close look at the one on the right side here. So for example, in the red blood cells, me as a hematopathologist, I have to decide how many macrocytes per field. And if they are 11 to 12%, then I should call this moderate 2+. Or if there are more than 5 ovulocytes per high power field, then I should call this 3+. And as you can see, the criteria is different with each cell type. So for me to do that, that's insane. It's almost impossible manually to do. So this is not even achievable. However, the automated system and AI will make this achievable. And I think this is where I would not be surprised if we see this coming very soon with some recommendations to standardize. I'm not going to spend much time here, but essentially the remote connectivity with the clinician is the main thing we want to achieve here. I'm going to move into assisted diagnosis. This is a paper by the Spanish group in 2015. They were able actually to use some feature extracted geometric features or color, texture, and cytoplasm features to separate the lymphocytes based on the disease. So essentially, they can tell if a lymphocyte is a normal or hairy cell or CLL based on this. And you can see the performance. The left side is the reference, and the top one is the predicted. You can see they can predict if a normal lymphocytes more than 99%, which again, this is quite significant. So basically, they concluded that the method reaches a very high precision in the recognition of lymphocytes, and they could design a future diagnostic support to help. So what we think in the future is going to be something like this. It comes in the lab, no matter where physically I exist, I would receive a text, tell me, we have received a CLL case or an AML case, and then I just click and I will be able to see even the bone marrow or aspirate smear and give the clinician a call. I want to touch very briefly on this study here as well, which came in 2019, which basically AI can separate the MDS and aplastic anemia. This is for those who do Hempath, they know that this is a difficult diagnosis to make, even with all the molecular testing and all the classification. This really is a difficult classification to make, and actually have quite a bit of diagnostic implication. They had more than 600,000 blood cell image from 3,000 peripheral smear. They were able to classify the 16 cell type, whether it's lymphoid or myeloid or whatever, using this TISCI plot. And this is really the sensitivity and specificity for separating it. But what they have done is beyond that. Essentially, they were able to separate the diagnosis of aplastic anemia and MDS based on a set of criteria that they have looked for the shapes of the cells. You can see the top three that had the most discrimination essentially is the pseudopilcarioid abnormality. This is a specific abnormality for myelodysplastic syndrome, and the granulation of the cytoplasm. They have shown an impressive sensitivity and specificity and accuracy with the sensitivity of 100%. This is another study that done by the same Spanish group that were able also to tell the dysplastic features of the cells, of the myeloid cells, with a very high level of accuracy. So we know this work. This is another group. This is another study that takes this beyond just the morphology. So this is from the University of San Diego, California, where they actually, what they did, they looked at all blast that was called on the aspirate smear or on the peripheral smear, and they went a month before, and they looked at, they asked sets of questions in the lab information system. And does this patient had mobilization drugs? That this patient had steroids? Was there any other abnormality flagged by the CBC, LDH, cultures, infection? And it actually was impressive that they were able to, every single diagnosis was significantly, each single question was statistically significant in providing answer that can actually separate and answer the question if this is a blast because of neoplastic condition or because of infection. Interestingly, the only one that didn't really correlate very well statistically significant was the organism identification, which I find this quite interesting. So I'm gonna skip now and go into the ancillary testing by flow cytometry. This is still in print, but this came from the Utah group. They looked at over 3,400 cases, peripheral blood cases, with the 10 color tubes for B cells, and they did feature extraction and dimensionality reduction, basically UMAP, on the raw flow cytometry data without gating, which we have done a very similar work here, and it's we have found very similar findings. This is followed by random forced classification to classify cases without gating into normal or abnormal. And you can see on the right side, there was a lot of diagnosis. The majority were normal, but there was a set of different diagnostic. So the final training sets included 21 million events that fit into the UMAP algorithm. and generated projection of the data in two-dimensional space for each of these 21 million events. For each case, as you see here, a projection of these events was converted into two-dimensional histogram and followed by the random forced classification with a 10-fold cross-validation to address the overfitting of the data. And as you can see here, for those who do flow cytometry, like if you focus on the CD5, for example, you can see the population in the left lower corner. We know these are probably NK cells because they are negative in any of the others. The red, the bright red is positive, the blue is negative, and the darker it is, the more you would know the expression level. You can see also on the CD10, this big population is the granulocyte population. What I want to point out here, this is my last slide here, is that and the result, you can see the performance of the algorithm did very well in essentially most of it. Whether it's a B-cell malignancy, they have done very well. If it's a CLL, a specific question, does even better. You can see the T-cell didn't do very well, and this is on the D plot, and this is because they, if you remember at the beginning, I said this is a B-cell tube, so it's not designed for T-cells. But what was impressive for me to see the AML, how well it does on the acute myeloid leukemia from a B-cell tube. And obviously on the F, you can see the algorithm was able to predict what additional tubes can be performed once you have done the analytics of the testing. So essentially, they had more than 90% accuracy for all B-cell malignancy, higher if there is a specific algorithm. If they adjusted the classifier to 100% sensitivity, they would have only 14% sensitivity. So hypothetically, this would allow for 11% of the cases to be auto-verified without even any pathologist laying an eye on it. So their conclusion is improved quality controls, and decreased turnaround time, and staff workload. I'm actually going to skip this here, and I think I'm off time, so I'm going to stop here and take questions.
So Mohamed, thank you so much. This was a great overview of you personally using these tools as a hematopathologist. How do you view the role of convergence and between industry, your institute? Like, you are in a unique institute because of your reference lab and everything else that's going on. But for average pathologists in the community, when do you think, what can be done to make these tools available? Partnership with the industry, partnership with academics. How do you, one of the goal of this workshop is to bring these processes together?
Yeah, that's a fantastic question, Anil. So first of all, I would start by saying I do not believe academics or even hospitals are going to be able to take this forward alone. Because we are continuously worried about the cost, and also we are limited in the lab. And I have lost 27 years. I have been in the labs. We are limited in the labs by the technology. So we can do only what we are given to, and this is part of the reason what's given to us by industry. So that's part of the reasons why I showed the limitation on the high magnification. A lot of this post modification or post processing for images that may allow 20x or 40x, it's going to become very hard. And even if we prove the principle in academia, it still need the interaction and the partnership with the industry. Now we have to keep in mind that priorities are different. When we are talking universities and academic, priority is always education. Priorities and innovation might be lower in the priority. So actually, one of the main reasons why the resources are also limited in a way. When you are talking about industry, you are having innovation is the top priorities, and actually this is where the perfect synergy would happen if the right partner comes. Now with our institution, we actually have a significant partnership with the industry, which we are able to move many of those innovation forward. Maybe I will stop here.
Yeah, So no, I totally agree, and I think that's going to be an ongoing discussion with our, as part of this workshop and the next two workshops, is going to try to bring in more perspectives from the industry, more perspectives from pathologists and computer scientists. So again, thank you. There will be more questions on the chat line, and we'll send them to you. Your talk will also be available to the participants. So if they have any questions, they might email you. So thank you so much for taking time from your busy schedule to be part of this workshop. We really appreciate it.
Thank you. I
So
appreciate it.
thank you. And with this, I'm going to hand it over to Raghu to introduce our next speaker.